walking through the Bruxer department the other day and I saw my favorite sticker. That's right, it's QC Alert. This means that somebody in QC needs to take a closer look at this case and see what's going on. And this is a dentist actually who I know, actually a pretty good account. She's been working with us for a number of years and recently has started to experience more remakes than she wanted to. And I think really it comes down to the impression more than the prep. You know, if you give us an absolutely perfect prep and then the impression doesn't have the margin represented all the way around, there's always going to be a chance once that crown goes to place there could be some recurrent decay. But even if you do a prep like I used to do, where I would under-reduce it or sometimes over-taper a prep in the anterior, but you take a perfect impression of it, the lab can still send you a reduction coping so you can fix the prep on the fly. And if you have a great impression that shows the margins clearly, then it's going to be sealed and we're possibly or probably not going to get recurrent decay around that crown. So if I had to pick between the prep and the impression, I have to pick the impression as being the more important part. Just because on the prep, if it's not reduced enough on the lingual, there's reduction copings and other things. The prep can be fixed at the seat appointment while the impression cannot. So this is taken in a plastic. It's got pretty good stiffness to it. It's a thicker plastic double arch tray. And this is an impression for a crown on a second molar for a Bruxer crown. It gets a little close on the side over to the plastic on the tray, but it's really more the look of the margin itself if we look at the margin on the impression. And please let me be the first to say that every impression I took for the first 15 years of my career looked exactly like this one. My assistant, I would put the impression tray in the room, walk out of the room, walk back in 5 minutes later, and I'd say, how does it look? And my assistant would say, did we get the margin? And I'd look at it and I go, yep, we got the margin. And I would say that because, I don't know why I'd say that. I'd say that because it looked like we got the margin, but the way I understand things today is that unless you can see impression material beyond the margin, you're never quite sure if you got the margin or not. This dip right here is a good example. It's hard to tell whether that's exactly what the margin does or if in fact that's short of the margin because we don't have any material beyond the margin. And so what I used to accept as an impression like this that was okay to be sent to the lab and would do all right, today I don't feel that way, and it's not because I've gotten any better as a dentist. If anything, my eyes have gotten better in terms of recognizing what it's supposed to look like, what a good impression is supposed to look like. And as a result, there's a technique, the TwoCord technique that I blab on about all the time that allows me to get that result without waking up with all kinds of new skill in my hands that weren't there before. So when you take an impression like this, and when the end of the impression, the very edge of it, is also the margin, what happens is you pour it up in the lab, and granted, most dentists don't have access to be able to see this while it's still in their office, but the prep goes down and then it just stops right against the stone. And there's no real way of telling, if that is in fact the end of the margin. You have to kind of trim it there and hope for the best. And, it's not a perfect prep in some other areas, but it's close enough where if it was a great impression, it could probably be worked with. So as I talked to this dentist, I sent her a couple pictures. And just a couple pictures that I want to share with you that really kind of show what I had to burn into my mind about what an impression is supposed to look like when you look at it before you send it out. One of the big advantages of digital impressions is that when you take a digital impression, you look up on the computer screen, you don't see this. You don't see this negative image of an impression. You can look at the worst impression. This is far from it. But when you look at a really bad impression, when I show it in a lecture, everybody oohs and ahs because there's something awfully wrong with it, but you can't specifically say what it is. Once it's poured up and you look at it, then you go, oh, that's what's going on there. That's what the problem is. And so with the digital impression, instead of looking at a negative image like we have to with our polyvinyl impressions, when you look on the computer screen with the digital impression, you see a virtual model. And so this is what you get to see is essentially what the lab sees when we pour it up. So for us, it's kind of like cheating because we look at this. We don't really even look at your impression once it's poured. We can see all the information we need to see right here as we look at this. And of course, you don't have, as dentists, we don't have the ability to see that when we look at this. We have to kind of interpolate it. So we need to get good at looking at this and know when it's going to lead to a good model. So here's the picture that I sent her. And it's a picture of an impression that I took, but my assistant could have taken it. Anybody could take it because it got everything to do with the fact that it's the TwoCord technique. That's what gives you this kind of result. And so as we look at this, we can see the margin represented around here. That's from that round burr in the reverse preparation technique that I use. And then because of the TwoCord technique, we can see where the edge of the margin is, right at this junction, and then there's impression material about 1 millimeter beyond it. So it's this fin, this wall of material that goes around the perimeter of the prep that's beyond the margin, apical to the margin, that lets the technician know the margin is right there. I mean, it's clear as a bell where it is. In fact, trimming the die on a pour-up of an impression like this, you really don't need a burr. You can almost use your fingernail and just snap away the stone that's going to be out here and expose the margin. An impression like this does not need an expert 20 years of experience technician to be able to find the margin. This is the kind of case you give somebody who's been at a dental technician school for 2 weeks, because it's so simple you could teach one of your kids to do it. So this is what I wanted her to kind of memorize and get used to seeing on her impressions. When I looked at her impression, it was clear that it was just a one-chord impression. I mean, I've taken so many one-chord impressions, I know what they look like. And when you see this, this is what a two-chord impression looks like. I can tell factually this is a two-chord impression. The only other thing it could be is a diode laser, but I know it's not because of this thickness right in here. So the thickness of the impression in this area, which is important as well because it won't bend back and forth as we're pouring in the die stone. The thickness of this impression is because this is actually impression of the 00 cord, the bottom cord that stays in the sulcus during the impression, which is why there's no bleeding, because we get an impression of that cord. So another example of a two-chord impression, and this is a little more detailed close-up of that margin, is this impression right here. And again, you can see how wide this edge is right along here. And it's usually kind of rough because this is an impression of the retraction cord that's sitting in the sulcus. And again, we have this material beyond the margin that you can see in this area. And you can see where exactly where the burr marks are on the margin and exactly where that transitions to the root surface of the tooth, because this is an impression of the root surface of the tooth just apical to the margin. It is clear as a bell where this margin is. There's no question whatsoever. And by giving the technician an impression of the root structure here, of this 1 millimeter of root surface, now they can really dial in the emergence profile too. And when this crown is designed, whether it's digitally or by wax, they can really blend the gingival third of the crown with the emergence profile, with the contours, I should say, of this root surface here. In fact, if you're taking impressions like this and reducing enough and not getting just stunning crowns back from your lab, whether it's us or somebody else, you have a right to be angry and should probably switch, because this is as good as it gets. This is the pinnacle that we're all shooting for. And again, the only way, there's two ways I know how to do it. One's with the TwoCord technique and one's with a diode laser. I'll show you both of them real quick. But for me, the TwoCord's the more useful one, because that's the one I'm going to be using on anterior teeth. With diode lasers, I have a tendency to lose tissue height on anterior teeth, and that's worrisome. So in the TwoCord technique, we've just teased out the top number 2 cord here, and you can see this dark line here in the sulcus. That's the 00 cord that's still in place. Because that cord's in place, there won't be any bleeding. As soon as that cord comes out, there will be blood, just like the Daniel Day-Lewis movie, which should have been about gingivitis and should have been about pulling retraction cord before impressions. If you just use one cord, when you pull it out, there will be blood. Anytime you put one cord in and take it out, it bleeds. If you put 2 cords in, take the top one out, it doesn't bleed till the bottom one comes out, because that's the one that's in contact with the inflamed base of the sulcus. When you pull it off, it's like ripping off a Band-Aid. The other problem with the 1-cord technique is when you put it in, it drops underneath this gingival cuff down to the base of the sulcus. So when you put 1 cord in, it provides vertical retraction of the tissue, away from the margin. But it's not until you put the 2nd cord in that you get lateral retraction and move the tissue laterally away from the margin. In fact, when you take that cord all the way out, you can just see there's a moat around these teeth, around these preps. There's just a huge moat, and you can see that it'd be almost impossible to miss this impression. I don't even know if you need to syringe material into place. You could probably mix up some alginate and just flick it at the preps and then seat a tray on top of it and still have it work. But regardless, we'll do it the right way. And you can see that the tip fits right into that sulcus, and as we express the material, it just flows right in front of us in that sulcus, giving us an impression of the margin of the preparation, and you can see that distinct line where the margin stops, and then it's also going to give us an impression of this 1 millimeter of root structure apical to the margin. so the technician will be able to blend the crown with the shape and the contour of that root surface. So when the impression is taken out 4 minutes later, again, it gives us that same two-chord impression look where we can see the margin and then a thick band, a big meaty band of impression material beyond the margin, like a Great Wall of China is always how I describe it. It should not look thin like mine used to look, because in the one-chord technique, I'd rip the one chord out and then I'd try to squirt the impression material in before the sulcus filled with blood, and that's kind of a hacky way to do it. This is the prototypical kind of iconic look for the two-chord impression technique. I'm not a big fan of lighter wash materials, by the way. I think these are a little hard to read, which is why I like a darker syringe material, I should say. Here's another case. We didn't replace any existing restorations here, so we don't have really many subgingival margins to speak of. So I'm going to go in and use a diode laser around these teeth just to expose the margins a little bit more, and then we're going to place some sort of retraction paste on top of it. Not to retract really, it's just kind of because we've used a diode laser, so the tissue's not going to grow back that quickly. I'm using this because it's got aluminum chloride in it, and that's an astringent material that's going to stop any bleeding that might have occurred because of what we did with the laser, or any seepage afterwards that might happen. And then we rinse that off afterwards, and you can see that we've got a nice look. We've used the diode laser, so you can see some little tissue tags that we tried to clean up with a little Ultradent brush and some hydrogen peroxide, but we left a few there. But again, we have that same type of moat around the preparation, and we were able to do this with the diode laser, but because of the thickness of the tip, when we do this, we lose a little bit of tissue height. Not a big deal here on these molars, but a much bigger deal on anterior teeth, when losing tissue height could really end up being a mess. So if we go back to that first picture again and look at that, for example, or even this second picture, and see that fin of material, and let's compare that then with the impression that was sent in by the doctor and kind of look at them side by side, and you can see the difference that is made by having that excess material beyond the margin. So in my list of what's required for an ideal or a highly acceptable impression, we need to have some impression material beyond this margin, so we categorically know where the margin is. And the only way to get that I know of, the two ways, are with the TwoCord technique, which I know some dentists don't like to do because it's kind of laborious. Here in California, I put the first 00 cord in during the prep sequence, and then my assistant places the top cord, the number 2 cord, on it after I leave the room when I'm done with the prep, and she gets me 8 to 10 minutes later to take the impression. Or we could do it with a diode laser, and honestly, I'm much more likely to do that type of troughing with the diode laser in the posterior. In the anterior, I use my diode laser all the time for recontouring gingiva to level out gingival levels on teeth 7 through 10, for example. You could also use an electrosurge. I just say diode laser because that's become my instrument of choice, mainly because it can be used around implants and other metals, whereas you can't do that with an electrosurge. So commit that picture to memory, both of those pictures where we have that material beyond the margin. If you can look at an impression in your office and see that material beyond the margin, you know you're sending it into the lab, and that it's not going to end up with a QC alert sticker. It's going to end up with a sticker with a big happy face on it and a high five, because our technicians are going to have a much easier time fabricating a quality restoration for you and your patient.